for referral for renal biopsy, where we are talking of concurrent pharyngitis, normal complements initially, complements low by 8 weeks, glomerular filtration rates below 50% of normal, nephritic syndrome, persistent hypertension, Simantoy Helen, you risk being chased out of class. And those who are using cameras, please use those cameras very responsibly. We are talking of persistent hypertension beyond 2 weeks, hematuria beyond 1 year, gross hematuria beyond 3 weeks, oliguria beyond 2 weeks. If there's no drop in BUN or creatinine after 2 weeks, and patients who sustain high hypertension every time they manifest, they present in the hospital. When it comes to follow-up, we are talking about BP urine test every visit, 4 to 6 weeks. Visit in the first 6 weeks, 6 months, 4 to 6 months follow-up. And we also talk of urinalysis every time the patient presents in the hospital. The outcome of treatment, we don't talk about death as an outcome, but unfavorable outcome may occur, especially when they're in the acute stages of the disease or in the chronic stages of the disease, when the BUN is more than 25 millimoles per liter. Unfavorable outcome may also occur because of hypertension, sustained hypertension, azotemia at varying times, and abnormal urine sediments. Those ones can also bring about unfavorable outcomes. End-stage kidney disease occur. So when it comes to abnormal urine sediments, which is exhibited all the time, that only occurs in 5% of the patients. Otherwise, end-stage kidney disease is only witnessed in less than 1% of patients. So we can say with good treatment, the outcome of treating AGN is always favorable. Karaoke, and Samuel, please mute your microphones. So, in summary, we need to make the right diagnosis by doing the appropriate investigations and taking the right history and doing physical examination. We must rule out other causes of AGN so that we can settle on specific management. Always do thorough examination. And also, regardless of the age of the child, we need to also monitor blood pressure. Those who qualify or meet the criteria for referral, they should be referred in good time. Otherwise, patients who have AGN require proper counseling, and even their relatives should know what to expect out of treatments. So that brings us to the end of presentation on AGN. Let's move to the next topic, which is nephrotic syndrome. Anybody with questions, please keep them so that we can have them addressed last minute. So when you talk of nephrotic syndrome, these are renal disease characterized by massive proteinuria, edema, and hypobilirubinemia, Many instances, we may also see hyperlipidemia, but this may not always be there. Hypercholesteremia is also frequent, but not invariably present with lipidemia. So these are features that we are likely to see when it comes to nephrotic syndrome. Unlike in AGN, where hematuria and a possible proteinuria were the predominant features. This one is not only proteinuria, but massive proteinuria, leading to edema and hyperbilirubinemia and hyperlipidemia. The causes of nephrotic syndrome are the same as those of AGN and renal failure. But over and above, we also have AGN as a cause of nephrotic syndrome. We may also get nephrotic syndrome resulting from electrolyte imbalance. It can also occur in chronic infections of the kidneys, and it can also occur as a result of urate nephropathy. Apart from those mentioned, we also have plasmodium, malariae, syphilis, diabetes mellitus, sickle cell disease, allergens like pollen or bee stings or poisons, tumors like breast cancer or BPH. But the commonest cause of AGN remains post-streptococcal glomerulonephritis. The pathophysiology of AGN occurs due to various factors. One of those factors is damage to the glomerular apparatus. This will manifest with leakage of protein, especially albumin, and there is massive between 2 to 5 grams per day. I've said, please ensure your microphone is muted. Anybody not muting, will simply throw you out of class. So damage of glomerular capillary endothelium, that leads to leakage of protein, especially albumin. So in normal circumstances, the glomerular capillary is negatively charged, and that repels the proteins, which are also negatively charged. So this repulsion leads to increased catabolism of protein by the kidney. Due to the same loss of capillary matrix or endothelium, loss of protein is observed. That leads to hypobilirubinemia and reduced oncotic pressure. The reduced oncotic pressure, together with the natriuretic hormone, increases vasopressin release, and a combination of the three will lead to edema, CCF, and progressive renal failure. So all those factors overlap, and once they overlap, then you're likely to get the massive edema that is noticed, the CCF, and progressive renal damage in acute glomerulonephritis. So these are the events which take place: decreased synthesis, of albumin will be reduced, increased albumin catabolism. All this can shift downwards, where you get the initial volume being raised. That is where we are talking about interstitial volume. There's increased vasopressin release. The shift of capillary fluid to interstitial space will lead to plasma volume reduction, reduced renal perfusion, increased renal aldosterone, reduced sodium and water excretion, and continuous ingestion of continuous ingestion of a possible that does not seem to be okay. Just increased ingestion of salt leads to high salt concentration and water retention. So that circle is complete. You can organize it. We have types of lesion being a major factor in pathophysiology. In types of lesion, in nephrotic syndrome, we have three types of lesions. We have minimal change, we have membranous proliferative change, and we also have proliferative change. So minimal, membranous, and proliferative. What happens in minimal change? This is a commonest lesion seen in children. In histology or electronic microscopy, the cells will indicate normal glomerular apparatus, including the capillaries. So at that particular point, you can only suspect autoimmune reactions. When it comes to membranous proliferative change, this is common in patients who are exposed to drugs, have had history of malaria, have had history of SLE or ongoing, and have also had malignancies. Membranous proliferative change is very common in the tropics. What are some of these characteristics that make it unique? It is different from the minimal change because there is thickening of the basement membrane of the capillary wall. When it comes to proliferative, as the name suggests, there's proliferation of the mesenterial cells and formation of lobular glomeruli. Another change that occurs is because of hyperlipidemia. This leads to increased secretion of low-density lipoproteins from the liver with reduced albumin synthesis. If accompanied by any impaired lipolysis, then we can get increased low-density lipoproteins, but high-density lipoproteins remain normal. Albumin is known to bind to free fatty acids, which is the transporting agents. So since there's loss of albumin, there is subsequent high levels of cholesterol in blood due to accumulation of low-density lipoproteins. As we know, low-density lipoproteins are mobilized from the liver to the peripheral tissues, and they're the ones which cause serious vasoconstriction. What are the clinical signs and symptoms? Edema, what we call anasaka, is first on the list. That can be seen on the face or upper extremities or even the genitalia. It becomes worse in the morning and may improve in the course of the day. The urine itself has heavy proteinuria. Blood has hypoalbuminemia, but there will be increased serum levels of lipids because of low-density lipoproteins. Features of underlying disease may also be seen, like in SLE, you'll see what we call the butterfly rash. Features of malaria may also be seen. You may also have features which occur because of low serum proteins. These include edema, fatigue, anorexia, diarrhea and vomiting, and relapse of the infection because of subsequent immunosuppression. When you examine these children who have nephrotic syndrome, first of all, you'll appreciate generalized edema, followed by respiratory system findings like dyspnea and signs of pleural effusion. Abdomen will no hematuria. So in nephrotic syndrome, there's no blood loss. What is lost are the proteins. Then, how do you diagnose nephrotic syndrome? Through urine, you can do analysis and microscopy. Analysis will indicate massive proteinuria, up to 3 grams per day, 3 to 5 grams per day. Microscopy will indicate minimal RBCs, but even when they occur, they are actually in the form of casts. The blood will show low serum levels of albumin and high cholesterol level due to high synthesis from the liver. Specific investigations can target maybe syphilis, VDRL, blood from malaria parasites, random blood sugar, assault, blood fluorescent anti-nuclear antibodies. This is one single feature which diagnoses systemic lupus erythematosus. So once you find anti-nuclear antibodies, then you start suspecting SLE. Sickling tests can also be done because sickle cell disease can also compromise the renal functions. Renal biopsy confirms everything. Tests for referral for renal functions like blood for urea and electrolyte, serum creatinine levels and creatinine clearance, all those ones should be done. What are the differential diagnoses of nephrotic syndrome? CCF tops the list, liver failure, and ureteric edema, which can occur because of wasp or bee stings, or may simply come as a result of allergic reactions. Multiple myeloma, severe malnutrition, and severe anemia may also be seen. How do we treat nephrotic syndrome? It begins with the restriction of salt intake. Then you use diuretics. Diuretics are very important because in nephrotic syndrome is the low density lipoproteins which are lost. We must prevent potassium depletion, and this is best done by giving spironolactone. Unfortunately, spironolactone is a sulfur-based drug and sometimes may trigger some reactions. Encourage the patients to eat ripe bananas and ripe oranges and even tomatoes because these are the primary sources of potassium. We must restrict fluid intake by keeping input-output chart. Any losses through insensible loss must be replaced. Normal diet can be instituted unless there is an issue with the renal failure or liver failure. When there's very low hypobilirubinemia or when there is hypobilirubinemia, then you need to infuse albumin. The use of corticosteroids has been there for a long time. I know in KNH we used to use pulses. So prednisone is key in the management of nephrotic syndrome because it's a corticosteroid. It must be used as a dose of 1 milligram per kilogram body weight per day to a maximum of 60 milligrams per kilogram body weight per day. These pulses run between 6 to 8 weeks. In case there's any resistance to steroids, then you need to add other drugs like cyclophosphamide in order to get better results. Cyclophosphamide should not be used for more than 2 doses because it has the following side effects. It can compromise the bone marrow, leading to bone marrow failure. This can be relative bone marrow or absolute. Some children may exhibit alopecia, which fall out of hair. It can suppress the immunity, can suppress GIT, epithelium, and can lead to GIT bleeding. Fetal abnormalities, the factor number 3 and factor number 6 only applies to adults. Where there is specific cause like SLE or malaria or diabetic mellitus, these ones must be treated on merit. So general treatment and specific treatment are instituted. What are the complications of nephrotic syndrome? We are talking about acute renal failure and recurrent infections because of massive loss of proteins leading to loss of albumin, and therefore the synthesis of immunoglobulins and cellular components may be compromised. It is important to note that tetracycline and nitrofurantoin should never be used in nephrotic syndrome because of their specific preference for the renal system. These are drugs which are largely excreted by the kidney. So when you use them, then you're likely to cause more strain or tension in the renal system. Then these patients are also likely to have very poor outcomes because of low immunity and renal thrombosis. Septicemia is quite common in these patients. And with those many remarks, I beg to conclude, or I beg to stop my presentation and welcome any question. So any questions so far? If there are no questions, then we need to stop there. I will call upon everyone to make better notes. These are simply lecture notes. We have reference books where you can get a lot of information about AGN and acute and nephrotic syndrome. So until next time, let's keep it there and remain safe the rest of the week. Thank you. Aging is followed by a latency period of about 7 to 14 days, especially if it is from the pharyngeal origin. If it is from the skin origin, then the latent period can last up to 6 weeks. Initially, the edema may not be obvious, and even ascites and ulcer may not occur. In fact, they rarely occur in children. However, 75% of these children usually have elevated blood pressure, and some, in rare instances, there is hypertensive encephalopathy, but this may resolve after a diuresis. Oliguria may be noticed, but it is always transitory. There may also occur increased frequency of urine, dysuria, abdominal pain, and pain radiating to the back, what we call the back pain. Unless it is crescenteric in nature, anuria is largely rare in these children. The extracellular fluid expansion leads to orthopnea and raised jugular venous pressure, and that may be accompanied by tachypnea and tachycardia. In 1% of the cases, we see rapidly progressing glomerulonephritis. 99% may not be as progressive. The fluid overload resulting from all those pathological changes ends up leading to congestive cardiac failure, accompanied by pulmonary edema. There may be severe oliguria on anuria, and eventually that may lead to nephrotic syndrome. By the time it becomes nephrotic syndrome, up to a third of the patients will have severe hematuria. Other 2/3 of the patients may only have hematuria expressed in urine, what we call hematuria, microscopic hematuria. On physical examination of these children, we will be able to note the following on general examination. They may be pale, there could be lymphadenopathy, and there could also be edema. When you look at the other systems, the ENT may exhibit ENT lesions. From the skin, you may be able to appreciate the malar rash, the evidence of impetigo, rash on the external surfaces of the extremities, and the cardiovascular system. BP will definitely be raised. And if BP is raised, please try to rule out subacute bacterial endocarditis, especially patients who are not having CCF. What do you find when you examine the abdomen of these children? There will be tender hepatomegaly, which is largely because of congestive cardiac failure. Any tenderness in the loin will be appreciated, but you need to also do what we call shifting dullness in order to determine the amount of fluid in the abdominal cavity. The respiratory system, you may appreciate any features of pulmonary edema. CNS, many children may manifest with change in sensorium. In the genitalia, there may be scrotal or labial edema. So you need to go further and also carry out investigations if the combination of history and physical examination is not conclusive. Urinalysis should be the first thing to do. Usually in AGN, the specific gravity of urine is quite high. This urine may show some hematuria or may have very high levels of protein, which can be quantified up to 4+. And sometimes this brings a problem, especially when it comes to the diagnosis of nephrotic syndrome. So acute AGN can also have what we call nephrotic, may be accompanied by some evidence of nephrotic syndrome, but this may be subject to confirmation later. Again, when you do urine microscopy, up to 80% of cases have RBC casts. There may be a few cases of granular and hyaline casts. The urea, electrolyte, and creatinine are usually high. And if the glomerular filtration rate is below 50% of the normal, then you will also appreciate changes in serum bicarbonate, calcium, as phosphates. You may also appreciate serum albumin. Serum albumin may be low. Blood sugar may be low due to poor feeding, which accompanies this disease. So you may do full blood count, peripheral blood film, and even ESR. You may also do other tests. Assault is important to do, and most of the time it is positive, but the levels may not be reflective of the prognosis or severity. You need to do serious titers, which gives greater confidence in terms of following the diagnosis. Cephalosin O is bound to lipids in the skin, and that explains why there's low levels in pyodermal related AGN. This is AGN secondary to skin lesions. Other tests, depending on the circumstances, you may need to do anti-hyaluronidase, anti-DNS B, renal ultrasound, chest X-ray. Chest X-ray may be important, especially when there is respiratory distress, indicating pulmonary edema. Other tests include complement, C3, C4. You may do screening for HIV, hepatitis B surface antigen, hepatitis C antibodies. Malaria parasites needs to be checked because Plasmodium malariae is highly implicated. Throat swab is only sensitive in 20% of the cases, but 80% of the children are known to harbor Streptococcus as part of the the organisms that colonize the respiratory system, especially the throat. So as we make a decision on whether or not to treat, then it is important to know whether or not to treat them out of the hospital or within the hospital. So who should be admitted is the first question. We admit those who have edematous, who are highly edematous, those who have elevated blood pressure, especially if they are older. But we also admit those who have elevated BUN and creatinine, that is blood, urea, and nitrogen. So largely when you talk of post-streptococcal AGN, the treatment is largely supportive, because by the time the diagnosis is made, it's because of the circulating antibodies other than the bacteria itself. So depending on the complications, maybe AGN is related to primary kidney disease. It could be related to subacute bacterial endocarditis, or it could be related to shunt infection. They should be treated on merit. So we need to know the strategy for which AGN, on how AGN is treated. For these patients, we need bed rest as a necessity. Vital signs should actually be observed 4-hourly or as frequently as possible. We must institute strict fluid input-output charting. And we must also consider daily weighing because of the fluid retention. We must restrict salt and fluid intake. But the specific interventions with regard to AGN, we need to direct them towards the problem itself. If there's hypertension and fluid overload, we need to address that. If there's hyperkalemia, acidemia, or hyperphosphatemia, all those should be treated on merit. So we need also to confirm the likelihood of post-streptococcal disease. Let's watch for the onset of recovery, especially the first 1 week. During the recovery, you should anticipate polyuria. I think this should be done in pathology, revise the pathology of AGN, where you may go through the oliguric phase, you end up with anuric phase, and later on, there is polyuria. By the time the polyuria appears, then you need to stop any diuretics, and you also need to stop fluid restriction. After all, the child will be losing a lot of fluid through urine. Thereafter, please keep high index for the disease and the high index of suspicion. If the center where you are cannot completely address these issues, then you need to refer the patient promptly and also counsel on the need for follow-up. The discussion on AGN cannot be complete unless we also look at the diet. Fluid restriction through input must also take cognizance of the insensible loss. The insensible loss is estimated at 400 mils per meter square, and that should be added to the previous day's output. So when you do output with after the next 24 hours, you need to add 400 mils per kilo, 400 mils per meter squared. Dietary management must also observe low salt diet, although up to a third of the children may just require normal salt, but low salt diet is quite important. If there's hyperkalemia, then you need to address the low potassium diet. We need to institute low potassium diet because potassium is one of the electrolytes which can compromise renal functions. If there is hyperphosphatemia, then you need low phosphate diet. When it comes to fluid management, fluid and salt restriction must be exercised. Diuretics, especially furosemide, should be given in low doses because they may not spare other electrolytes. If there's fluid overload causing CCF or pulmonary edema, then we need to adjust the dose of diuretics accordingly. Patients with severe oliguria or anuric, then those ones could be cases that require dialysis, depending on the symptoms. For the children who have mild to moderate hypertension, they may not require any emergency treatment, but if severe, then we need to institute emergency treatment. Of course, blood pressure of 180 to 110 is almost unthinkable in children. If there is hypertensive emergency, no matter the age, you need to institute sodium nitroprusside as a continuous infusion, or you can put Levetol at a dose of 0.2 milligrams per kilo body weight. That should be pushed through intravenous route, and it should be pushed slowly over a period of 2 minutes. It can be increased at intervals of 5 to 10 minutes, depending on the response. So, labetalol and sodium furosemide are the major drugs used in high crisis. These crises are very rare in children, but they can occur. If it is not manageable at that point, then you need to institute hydralazine and later on nifedipine, depending on the age of the child. Cases of AGM require antibiotic therapy. So early antibiotic treatment does not prevent, but can go a long way to eliminate any bacteria that is still in circulation. So antibiotics, if the throat swab is positive, should be given empirically. Penicillin should be given for about 10 days. Penicillin is quite effective against streptococcal microorganisms. Screen all family members who are less than 15 years because they could be harboring serious problems. It is not lost that acute glomerulonephritis may end up with acute renal failure. When there's acute renal failure, manage hyperkalemia, manage hypophosphatemia, manage acidemia, and all these can be found in the protocol with regard to acute renal failure treatment. There could be needs. The eventual treatment basically is dialysis, and is what we call renal replacement therapy. But before that comes, then you need to do a bit of workup, especially rule out post-streptococcal AGM. This should be ruled out if there's no evidence of systemic disease. If there's evidence, it can be ruled in. If there's no evidence of systemic disease, evidence of post-streptococcal infection, the ASOT and the throat swab should reveal that. When there's low complement C3, but normal, initially there could be low C3, but later on that can be normal, especially after 8 weeks. When there's a recovery within 1 to 2 weeks, then diuresis, blood pressure, BUN, and creatinine begins to normalize. So these are features of post-streptococcal AGM. We expect normalization of urine, that is gross hematuria, should be expected to resolve in 3 weeks. Then resolution of the proteinuria should be expected in 6 months, and resolution of hematuria should be expected in 1 year's time. So when it is post-streptococcal, you're likely to see all that. In an event where there's kidney failure, then we need to know when to refer for a possible biopsy to rule out the underlying cause. or rule in the underlying cause. So indications for referral for biopsy are in the following: concurrent pharyngitis, normal complements initially, complements low by 8 weeks, glomerular filtration rate below 50% of normal, nephrotic syndrome, persistent hypertension running up to 2 weeks, hematuria beyond 1 year, gross hematuria beyond 3 weeks, oliguria beyond 2 weeks, and there's no drop in BUN creatinine after 2 weeks. Or for older children, if severe hypertension cannot be controlled. So these children should have the following follow-up. The BP and urine tests in every visit, 4 to 6 weekly visits in the first 6 months, 4 to 6 monthly follow-up until proteinuria and hematuria is resolved, and thereafter urinalysis needs to be done and BP monitored regularly. Please let's join the next session because we have less than 1 minute to do that. And please join in good time so that we finish up and start the next topic.